Hello! Welcome to this newest edition of the 12 Days in March review series for Step 1. My name's Kiran Mullur, and alongside me is my esteemed colleague, Matt Chabot. In this lesson, we'll be discussing testicular cancers. We'll be going into detail about how board examiners may come after you with questions related to this topic. As a reminder, a free PDF of this slideshow will be available on the 12 Days in March website. And without further ado, let's jump in and let's have some fun. Let's start by briefly reviewing the normal anatomy and histology of the testes. The primary role of the testes in the reproductive system is twofold: sperm production and testosterone secretion. There are three major cell types that you should be familiar with for purposes of Step 1. The first are your germ cells, also known as spermatogonia. These line the seminiferous tubules and produce primary spermatocytes. Next are the Sertoli cells, which also line the tubules and help support developing spermatozoa. Finally, there are the Leydig cells. These cells hang out in the interstitium and function to synthesize and secrete testosterone. So for the purposes of Step 1, it's helpful to think about testicular tumors fitting into one of two categories: germline or non-germline cell tumors. The germline cell tumors you should be familiar with for Step 1 are seminoma, embryonal, teratoma, choriocarcinoma, and yolk sac tumors. The non-germline cell tumors to be familiar with are the Leydig cell tumors and the Sertoli cell tumor. Lymphoma is a non-germ cell tumor, but is low yield for the purposes of Step 1. The vast majority of testicular tumors fall under the germline category. In the next few slides, we'll go over some of the key buzzwords and facts to be familiar with when examiners talk about these types of cancers. So let's start with how we go about tackling a question about a person with a testicular mass. For Step 1, there are some important pieces of information in the question stem that will help point you to the right answer. First and foremost, we must determine that the testicular mass in question is in fact a testicular tumor and not another testicular pathology such as a hydrocele. To do this, we must remember that testicular tumors are most often described on Step 1 as being, quote, solid, rock hard, and do not transilluminate. If you see these words, you gotta be thinking testicular tumor. Nailing questions about testicular tumors on Step 1 comes down to histology, and to a lesser extent the gross appearance and the tumor markers. Thankfully, for each tumor, we will identify some of the key phrases that test writers love to use when describing these neoplasms that will help get you to the right answer. You may also notice some important parallels between these tumors and those described in the ovarian cancer lecture. So a typical question may sound something like, blank old male presents with a scrotal mass. Histological examination reveals some sort of pathological description. And the question may ask, what's the most likely diagnosis? Which tumor marker is this tumor likely to secrete? What's the best treatment? Or maybe what's the site of metastasis? So now with this in mind, let's start getting into some of the key features to know about these testicular tumors. By far the majority of testicular tumors are germ cell in origin. For the boards, assume these to be malignant. An important risk factor for developing any of these tumors is cryptorchidism, also known as undescended testes. This is an important point to take notice of when given in the patient's past medical history or when test takers ask about a child's future risk given pre-existing cryptorchidism. Because these tumors are solid masses, they will not transilluminate. This means that when a light source is held behind the scrotum, the light will not shine through. Contrast this with a hydrocele, which will transilluminate because the scrotal mass in question is cystic and not solid. The first and most commonly tested germ cell tumor is the seminoma. This will get presented to you most often as a unilateral, painless testicular enlargement. It is important to remember this tumor does not occur in infancy. So if you have a 3-year-old presenting with a testicular mass, cross seminoma off your list of possibilities. So how they describe this tumor. Here's where your knowledge of histological descriptors becomes very valuable. Seminomas will be described as a homogeneous mass with large cells with clear cytoplasm and a central nuclei, or as having a, quote, fried egg appearance. If you hear this descriptor, you'd better be picking seminoma. Can you think of another tumor that is also described as having a fried egg appearance on histology? That's right, dysgerminoma of the ovary. You may see elevated ALP and beta-HCG described in these question stems. However, these markers are not specific, so they will never be your only clue. Answering questions correctly about seminomas comes down to histology and the gross appearance, and much less to do with the tumor markers. Now let's talk about yolk sac tumors. This is the most common testicular tumor seen in children less than 3 years old. This is an incredibly unique feature of the yolk sac tumors, so if you see in a question stem that describes a 2-year-old wee lad with a testicular mass, you must be thinking about yolk sac tumors. Histologically, you'll see Schiller-Duval bodies. Test makers are rarely nice enough to give you this clue though, so instead they'll be described pathologically as resembling primitive glomeruli. Can you think of where else we've seen this descriptor? You're right, the yolk sac tumor in the ovary. These tumors characteristically have an increased AFP, or alpha-fetoprotein. While many of these testicular tumors don't have a specific tumor marker, this is a high-yield association you must know. Do you remember what other tumor will classically present with an increased AFP? That's right, hepatocellular carcinoma, or HCC. So to summarize, if we have an infant with a testicular mass, plus an elevated AFP, plus Schiller-Duval bodies, you must be thinking about a yolk sac tumor.
Hey everyone, Matt here. Thank you for tolerating the JV portion of our video. Now, on to varsity. Next up is choriocarcinoma. This is a malignant tumor of placental-like tissue, but test takers will describe them instead as being composed of syncytiotrophoblasts and cytotrophoblasts, which are in essence the cellular components of placental tissue. Recall that the placenta usually secretes the hormone beta-HCG, and choriocarcinoma, a tumor of placental tissue, is no different. Therefore, beta-HCG is almost classically elevated in these tumors. In your question stem, you may have a patient with a testicular mass who also has findings suggestive of gynecomastia or hyperthyroidism. While this may seem like a strange association, if we review our endocrine lectures, recall that beta-HCG shares a similar alpha subunit to TSH, LH, and FSH. A derivative question that could be asked on step 1 is related to the spread of choriocarcinoma. The question stem could give you enough descriptors so that you correctly identify a chorio, but then ask you how the disease spreads or the most likely site of Mets. Choriocarcinoma spreads hematogenously, most often to the lungs, where it will be described as having cannonball lesions. It will also spread to the brain. Next, let's review teratomas. As you probably remember from the ovarian tumor video, teratomas are tumors containing cell types from all 3 germ cell layers, the endoderm, the ectoderm, and the mesoderm. Unlike in females, however, mature teratomas in adult males are malignant. This is a key distinction to make between testicular and ovarian teratomas. If test makers are nice enough to give you a gross description of hair or skin in a testicular mass, then they handed you the answer, teratoma. They are more likely to provide a histologic description, so the answer isn't quite so obvious. In the image above, we can see islands of squamous epithelium, meaning skin, or ectoderm. These cells are clearly out of place growing within the testicle, so teratoma is the obvious answer. The last of the germ cell tumors is the embroil carcinoma. This tumor is pretty straightforward, and there are only a few key features to be familiar with for the purposes of your exam. The stem will classically describe a young male with a painful, unilateral testicular mass. Gross inspection would reveal necrosis and hemorrhage. Although lower yield, for completeness sake, the histology may reveal primitive cells that appear glandular or papillary in nature. And that's it. We've now covered the key pieces of information to remember for each of the 5 germ cell testicular tumors. Seminoma, homogeneous, fried egg appearance, and the most common. Yolk sac, occurs in children less than 3. Schiller-Duval bodies, aka primitive glomeruli, and increased alpha-fetoprotein. Choriocarcinoma, syncytiotrophoblasts and cytotrophoblasts, beta-HCG tumor marker, and the tie-in with TSH, LH, and FSH. Teratoma, 2 to 3 germ cell layers, malignant in men. Embroil, painful and hemorrhagic. Now we'll move on to the non-germ cell tumors. These represent the minority of testicular tumors, about 5%. The first of the non-germ cells is the Leydig cell tumor. These do have a few key distinguishing characteristics that you should be aware of for step 1. First, these tumors are androgen or estrogen producing, meaning that the patient in your question stem will likely be presenting with some features suggestive of hormone production. In children, this will manifest as precocious puberty, while in adults, this will likely manifest as gynecomastia. Do you remember which of the germ cell tumors that we covered can also cause gynecomastia? That's right, choriocarcinoma due to HCG sequence homology. The key histologic feature of Leydig cell tumors is the Ranke crystals. Test makers are unlikely to give you this buzzword, however, so they will likely describe them as eosinophilic cytoplasmic inclusions. If you see this description, they are talking about Ranke crystals and telling you that the patient has a Leydig cell tumor. To finish things up, we'll review the Sertoli cell tumors and testicular lymphomas. Sertoli cell tumors are benign and don't have any real distinguishing features, so you are very unlikely to have a question in which Sertoli is the right answer. They are more likely to appear as one of the answer options as a distractor. Testicular lymphomas are the most common cause of testicular mass in men over 60 and typically will be bilateral. These are not a primary tumor but represent metastatic spread from a lymphoma, and they tend to be aggressive. These will be most important in a question stem describing a man over 60 with testicular mass. There aren't many other key features to highlight for this tumor. Just be sure to always keep your patient's age in mind. The question writers would be required to describe the pathologic features if they were to pursue this lesion. And that's it for testicular tumors. Now that we've covered the common tumors to appear on step 1, let's try a question. This is a 25-year-old with a unilateral testicular mass. He has symptoms of weight loss, diaphoresis, palpitations, and nervousness. What does that make you think of? You're right, these are the classic symptoms of hyperthyroidism. What does hyperthyroidism have to do with testicular tumors? Well, which testicular tumor can present with signs of hyperthyroidism secondary to sequence homology with TSH? Right again, choriocarcinoma. Now, unfortunately, step 1 test makers love derivative questions, so it's not enough to just know which tumor this young man has. We need to be familiar with the histology of choriocarcinoma. Let's run through our options. A. Clear cytoplasm with central nuclei. This is the so-called fried egg appearance of a seminoma. B. Cells resembling primitive glomeruli. These are the Schiller-Duval bodies of a yolk sac tumor. C. Normal testicular histology. This is just a distractor. E. Eosinophilic cytoplasmic inclusions. These are the Ranke crystals that we see with Leydig cell tumors. D. Disordered cytotrophoblasts. That's right. Remember, this is a tumor of placental tissue. Therefore, it will contain cell types such as cytotrophoblasts and cystisotrophoblasts.
And that's it for testicular tumors. Thank you for watching this video, and we hope you found it useful. Good luck with all your studying. This is Kiran and Matt signing out. If you like this video, we hope you... And that's it for the testicular tumors. This is tough. This is tough without a script.
Hey everyone, Matt here. Thank you for tolerating the JV portion of our video. Now, on to varsity.